introduction and invitation. It's a pleasure to present here. And I think my talk basically is a nice continuation from some of the important issues raised by Krish, who is a pioneer in the MEG field. So I'm going to particularly focus on the question whether MEG might tell us something about the underlying neurobiology in schizophrenia. And schizophrenia, as most of you are familiar with, is still a very devastating psychiatric condition, and overall there has been very little progress in terms of identifying novel targets that basically improve the current treatment. And we believe that basically some of the measures that we can obtain in patient populations through MEG but also EEG maybe could help us to identify some of the aberrant circuit dynamics that Krish has highlighted. And this has already led, I think, to maybe a re-evaluation in terms of the basic physiological mechanisms. So there's lots of evidence basically in schizophrenia research that particular classes of GABAergic interneurons that are involved in the generation of high-frequency oscillations of the normal cortex are impaired in schizophrenia. And also there might be some contribution from NMDA receptors that could also drive some of these impairments. And as also highlighted by Krish, what is really nice about EEG and MEG is that basically we have readouts that we can obtain from patients that can be directly compared, for example, in preclinical models, and then allow comparisons as to, for example, a particular target is engaged or whether the signatures can be traced back to some very basic mechanism. So MEG is a technique that has been recently more applied, especially in the United Kingdom. So we have this MRC-funded network that is led by Krish that allows us to basically compare measurements. I probably would make the case that compared to EEG, we have a much improved ability to, in particular, measure high-frequency oscillations. I think this is one of the core advantages, and also it allows us maybe some improved source localization, but of course there's some drawbacks, and that's much more expensive and difficult to implement. So what do we see if we basically look at high-frequency oscillations in schizophrenia? This is some published data that we obtained a few years back, where we, for example, show such visual stimuli, so-called Mooney faces. So these are complex human images where all shades of gray are removed, and then participants have to basically make a decision, is such a face present or not in a particular display. And here's the time frequency representation derived from MEG traces at the sensor level controls. Here we have time, and here's the onset of a stimulus. And basically what we see in MEG in particular is a very pronounced increase in high frequency oscillations. So this is somewhat in higher frequency ranges than what you commonly see in EEG recordings. Again, the sort of transient response followed by induced activity. Now, if we look at chronically medicated schizophrenia patients, you already see by naked eye that this high-frequency oscillation is really very prominently suppressed. And compared to previous EEG studies, we find a much increased deficit, in particular in these higher frequency ranges that have a very high effect size of 1.26. And again, I think this is one of the advantages. We have a much better readout of these changes in patient populations. We can then also look at unmedicated first episode patients in the same paradigm and compare how they fare to chronic patients. So here we have the time frequency modulation. In red we have for chronic patients, and in blue these are the unmedicated first episode patients. And what we see is that the initial transient response is intact in the first episode patients, but they also show a strongly reduced induced response. So we see that these patterns are already present at illness onset, and thus raising maybe a question where we can use as biomarkers. If we apply machine learning algorithms, we can very reliably differentiate first episodes from controls. However, and this is a recurring problem, some of these signatures are not specific for schizophrenia, and thus raising the current sort of utility of these measures for diagnosis. Oops. That's too far. So we can also then interrogate the functional architecture of these networks by employing sophisticated beamforming algorithms and examining connectivity patterns, for example, through phase synchronization. And this then basically raises the possibility also to examine to what extent the interactions between brain regions are impaired at realistic physiological timescales. And this is a summary slide from some analysis that we've done in collaboration with Matu and Satu Palva in Helsinki, where we examine source space-wide brain networks in particular frequency ranges in schizophrenia. And what these regions show you, and these patterns here, are basically reduced connections in the beta frequency range that suggests that in addition to the amplitude reductions, we also have a large-scale failure of connectivity patterns that could underlie some of the perceptual and cognitive abnormalities. Now, Krish has already shown some very powerful data that these measures are potentially very robust for example, also potential biomarker studies. And in basically in collaboration with Lily, we've carried out some further measurements in healthy controls to see how well do these measures reproduce over repeated sessions. So we first looked at the auditory steady state response at 40 Hertz and 5 Hertz, which is currently the most robust oscillatory parameter that you can obtain in particular in schizophrenia patients, show even at this very basic level, they show a pronounced reduction in these high frequency oscillations. And what we find is that if we simply retest healthy controls at these different frequencies, both at sensor and source space, we find that we obtain a very robust effect, basically, that these measures, in particular in terms of the phase locking and frequency, that these measures reproduce very reliably, and so with an average ScZ value of 0.83, suggesting that these are very highly reproducible measures. What is quite interesting is if we try to recreate these patterns at the source level, you get a much increased signal-to-noise ratio. So there's some benefit for conducting these analyses at the source level, as Chris has already shown. So also basically then get an increased anatomical readout. Another measure that we have looked at that is a very powerful way of driving high-frequency oscillations, similar to what Chris is showing, but with a sort of added attentional component. So you focus here on these concentric rings, and these concentric rings, they expand at a given time point, and there is a change in the acceleration of these gratings, and then you have to button press. So it's a very sort of engaging target for attentional circuits, and it drives the high-frequency oscillations in a very nice way. In the normal cortex, you have a signal increase of 100%, as seen here in this blue amplitude, and here we find that schizophrenia patients already show a very pronounced deficit. So again, a very simple task, but you see that schizophrenia patients basically fail to a very pronounced degree to generate these high-frequency oscillations. We can then also look at the test-retest reliability. So these are unpublished data, and similar to what we find in the auditory steady state, in particular the peak frequency, which these oscillations can basically be generated, there's a high degree of reproducibility in normal controls. Now, one important question that has interested us is to what extent can we reproduce some of these oscillatory signatures or their alterations in schizophrenia by employing NMDA antagonists, in particular ketamine. So currently there is lots of interest in the fundamental role of EI balance parameter abnormalities in schizophrenia, and NMDA receptors are absolutely critical for achieving that, and we have lots of evidence both from genetics but also from preclinical work that NMDA receptors might be driving some of the circuit abnormalities in schizophrenia. And in preclinical work, a very sort of reliable signature is an increase in spontaneous high-frequency activity. And this was something that we were interested in, to what extent this can be reproduced in healthy volunteers. So we applied ketamine at at one time point and another one. We basically administered a placebo condition in healthy controls. And basically, if you subtract the time frequency signal from the baseline condition, we find that ketamine upregulates high-frequency oscillations in a sort of resting state condition to a quite considerable degree. And this is particularly pronounced in the high-frequency range between 40 and 80 Hertz, whereas the low frequencies are suppressed in healthy controls. We can then also apply source localization. And what you see are here beamforming images where we can identify those brain regions that are particularly targeted by the ketamine effects. And what is quite interesting is in particular subcortical structures, such as the thalamus and the hippocampus, seem to be markedly upregulated in response to ketamine in healthy volunteers. And this is quite interesting for schizophrenia because these signatures seem to be present at illness onset and might be driving some of the pathophysiological changes. We can then also look at connectivity patterns at source space, and what we find is in that particular thalamocortical interactions seem to be increased, maybe suggesting sort of a large-scale disinhibition of brain networks following ketamine. Now, the question is, does this tell us something about schizophrenia? To what extent are these patterns comparable to what we see at illness onset, for example, but also in chronic patients? So what I've done here, I've basically summarized different parameters that we can obtain with MEG. We have resting state power, we have the connectivity patterns, we have task-related gamma band power, and also, of course, we can obtain the ERP analog and MEG recordings. And what we see in healthy controls is that following ketamine, there is basically an upregulation in all these parameters, both in terms of the task-related power and connectivity, and in particular in the resting state. But this is quite remarkable that even during a task engagement, ketamine seems to drive or increase the high-frequency oscillations. Now, if we now compare this in particular with the early illness stages, we see that there's some resemblance to what we observe in unmedicated first episode patients. So there's some indication that also the resting state power and the connectivity patterns seem to be somewhat increased, but not to the degree that we see under ketamine. Similar, the ERFs are also increased, but what really sort of seems to differentiate first episode from the ketamine effects is the opposite effect on the task-related power. So ketamine does not, maybe not too surprisingly, fully recapitulate the patterns that we're seeing in first episode. But what is interesting is that some of these patterns seem to be quite different to what we see in chronic schizophrenia, suggesting that perhaps there's some contribution of an aberrant glutamatergic signaling at illness onset. This is consistent with spectroscopy findings, so we can also measure glutamate levels in vivo. Again, it's a very core readout that measures only general glutamate concentrations. But what we find is that if we look at meta-analysis of glutamate changes during the course of illness, we can see that basically in illness onset there seems to be an excessive glutamatergic transmission that seems to be declining with progressive illness. So perhaps these data support some of these findings that some of these parameters may indeed fit with a hyperglutamatergic state. Now, in the final few minutes of my talk, I'd like to look at the question whether we can develop a MEG biomarker for early diagnosis. So clearly, EEG and MEG measures, they tell us something physiologically meaningful about the circuits that we would like to target, but actually are also clinically meaningful targets. So a biomarker should not only measure an interesting signal, it should also correlate meaningfully with the clinical state or other important clinical variables. And this is something where perhaps some of the paradigms that we've been discussing are maybe not doing so well. So they measure physiologically interesting signals, but yet they don't really allow us to predict illness, and sometimes they don't even correlate very closely with clinical or cognitive variables. So what we're currently engaged in is a study where we're trying to identify young people who have a high risk for developing psychosis. So we know for a long time that prior to the actual onset of schizophrenia, there's a prolonged period of up to 5 years where young people show subthreshold psychotic symptom cognitive deficits that can be predictive for a later illness onset. So very similar to what we have in Alzheimer's disease. We have a period of up to several years called mild cognitive impairment where people are at risk for developing a more serious form of dementia. And so this is what we're currently engaged in. We're recruiting 100 young people at risk for psychosis. So we established clinical criteria that allow to identify these people. And normally they have a risk of developing schizophrenia within 2 years, between 20 and 30%. And many can compare at baseline. Do the respective imaging measures allow you to predict illness trajectory? So I cannot give you a conclusive answer to this question yet, but I can show you some very preliminary data, because this is an ongoing study where we can at least show that, for example, at this measure that I've already introduced, where we present these gratings that elicits a very high frequency response, that, for example, in the, this is not quite the correct slide, but what this actually should show you is that the at-risk participants show a attenuated high-frequency response already at the risk stage, it seems to be indicated that prior to the actual onset, there is already aberration in terms of these high-frequency oscillations. And similarly, a mismatch negativity paradigm that we've implemented shows that in controls, we have this very sort of pronounced mismatch response, but this is already quite strongly reduced in the acidic patients, suggesting that some of these abnormalities are already present at these early illness stages. But this, of course, begs the question, are these predictive for later illness transition? And this is something that we will address in the next few years. So let me summarize the main points. Schizophrenia is associated with abnormal oscillations and synchronization, and we hope that this may be informative for understanding basic physiological principles underlying the disorder. We can show that some of these changes in oscillations might be consistent with NMDA receptor hyperfunctioning. However, these might be more constrained towards the early illness stages, but they're also not fully consistent. MEG paradigms may be suited for biomarker discovery, so they're very robust, and they can also be implemented in preclinical work. But I've already raised this point. Maybe this is something that we can discuss later. I think we're still lacking well-established, physiologically meaningful, but also clinically meaningful paradigms that we can implement in both domains. And currently we have a number of paradigms, but sometimes I think their, especially cognitive or clinical relevance, is still maybe something that we can think about. I'd like to acknowledge the people who did most of the work. So some of this work was still done at my group, the Max Planck in Frankfurt, and currently this work is continued at the University of Glasgow, and here the funders. So the current high-risk study is supported by the Medical Research Council and the test research work by Lilly UK. Thank you for your attention. So the question was whether the differences between the unmedicated first episodes in chronic patients that we see in the MEG parameters, whether they are due to illness progression or due to maybe the effects of prolonged antipsychotic exposure. So this is something that we cannot disentangle currently. There is some evidence that some of the antipsychotics may, for example, impact on GABA and glutamate levels. So I could see that some of that might be driven by that, but probably not all of these effects. But this is something that we need to address in the future. Well, I think that's still something that is a little, little unclear. I mean, basically what you measure with spectroscopy is an aggregate signal of both glutamate and glutamine. So the various ways, I believe, how you can get an increased glutamate level. And again, this is something that we currently only have. We only basically have a very sort of general readout. So how this precisely relates to some of the synaptic abnormalities, I think that's still unclear. Getting ahead of myself here. So the question was, I mean, how can we use these measures for stratification? Do we need 500 patients in order to maybe provide some meaningful targets for a drug intervention study? I don't think we need 500 patients. I think what would be quite useful to establish in the first instance is really to see whether some of these measures are in any way related to outcome, to cognitive impairment, and so forth. And this is something that really hasn't been done. If you look at the literature, the large majority of studies are with 20 patients, sometimes the most 30, but they really haven't shown any strong correlations with any meaningful clinical variable that I know of. And this is, for example, a little different with mismatch negativity, where there are better data, either correlations with transition to psychosis, for example, with functioning. And again, we have these interesting measures, but I think their relevance for some of the clinical questions we have, I think, to me, this is really unclear, and in part due to the fact that the study so far only had very small samples and haven't really investigated these questions systematically. So the question is whether I have insomnia because I give ketamine to people and I don't know what I'm doing. I don't get insomnia about it, but again, similar question or similar problem. It's a very sort of rough sort of chemical manipulation of circuits. So clearly, again, from our data, you couldn't really tell that, but I think there is very detailed in vitro work that shows that the ketamine-induced effects on high-frequency oscillations very specific to particular NMDA receptors and interneurons. So I think there we have some reason to assume that we might be targeting some circuits that might be relevant.